Hello, my name is Megan Boudouin, and the name of my project is Impact of System-Level Opioid Stewardship Committee Initiatives on Opioid Prescribing in a Community Hospital. We have nothing to disclose. Improving opioid prescribing practices has become a major healthcare priority due to the marked increase of opioid misuse. It's estimated that 50 to 70% of hospitalized patients experience acute non-cancer pain and will receive at least one dose of an opioid during hospitalization. Indicators to assess safe opioid use in the hospital setting include tracking the number of patients on opioids who have a documented sedation assessment, such as the Placebo Opioid Sedation Scale, assess patients on IV opioids for more than 3 days for acute pain, and ensure these patients receive an appropriate bowel regimen for opioid-induced constipation, or OIC. POS is a sedation scale of tiered levels ranging from S, meaning the patient is asleep but easy to arouse, up to 4, which is no response to verbal or physical stimulation. This scale allows nurses to determine the patient's level of sedation during opioid therapy. The policy at Wellstar North Fulton is to document the POS score before opioid administration, and the patient must be reassessed 1 hour after opioid administration. Wellstar North Fulton established an opioid stewardship committee in April of 2018 to monitor and improve opioid prescribing patterns and patient safety. After forming in April, the initiatives from the committee were fully initiated by December of 2018. The purpose of this study was to describe the impact of opioid stewardship committee initiatives on opioid prescribing here at Wellstar North Fulton Hospital. The primary objective was to evaluate pharmacist interventions in reducing the number of days of IV opioid therapy and increasing the number of patients who receive an appropriate prophylaxis regimen for OIC. The secondary objective was to evaluate the impact of the committee's prescriber and nursing educational efforts by assessing the naloxone administration rate and the POS documentation compliance. This was a single-center study that took place at Wellstar North Fulton Hospital, a community hospital with 202 beds located in Roswell, Georgia, and we have about 45 med-tele beds. I completed an electronic health record review of patients admitted to Wellstar North Fulton medical telemetry floor receiving opioid therapy for more than 24 hours. This project received IRB exemption from the Wellstar Research Institute and was deemed a quality improvement project. Group 1 is the pre-intervention group of 75 medical records from April of 2018 to October of 2018, and Group 2 is the post-intervention group of 75 medical records of patients from January 2019 to July of 2019. I included patients that were over 18 years old receiving opioid therapy that was admitted to the medical telemetry floor for more than 24 hours. I excluded patients that were less than 18 years old, hospitalization less than 24 hours, those in the emergency department and critical care units, pregnant patients, and those classified for hospice. The current bowel regimen protocol for prophylaxis of OIC at Wellstar North Fulton includes Cinna with Docusate as first-line therapy, polyethylene glycol as second-line therapy, and bisacodyl suppository and normal saline enema as third-line options. The use of this protocol was considered an appropriate bowel regimen. So baseline demographics were similar between the two groups. The average age was about 68 in Group 1 and 67 in Group 2. And we also saw similar distribution of males and females in both groups with similar renal function. The first primary outcome was to evaluate if there was a reduction in the number of days on IV opioid therapy. We observed a significant difference in reducing the average number of days on IV opioids from 3.1 days in Group 1 to 1.9 days in Group 2. The number of days on PO opioid therapy was not statistically different, with an average of 5.5 days in Group 1 and 4.9 days in Group 2. There was a significant difference in the average total duration of opioid administration, with 5.6 days in Group 1 and 4.1 days in Group 2. The second primary outcome was to evaluate the number of patients with an appropriate bowel regimen for OIC prophylaxis. In Group 1, about 50% of patients did and 50% did not have an appropriate bowel regimen. In Group 2, we are making improvements with about 60% of our patients receiving prophylaxis for OIC and 40% are not. A chi-square test was done to analyze the data, and there was no statistical difference between Group 1 and Group 2. Looking at the compliance of PAWS documentation, we are about 57% compliant with documentation of PAWS, as shown in the figure from the results of Group 2. Another secondary outcome was to measure the proportion of study patients who received naloxone. 7 patients in Group 1 received naloxone, and the average morphine equivalent within 4 hours prior to that was 25.8 milligrams. We saw a decrease in these values for Group 2, with 3 patients receiving naloxone, and the average morphine milliequivalent was 15 milligrams. So in conclusion, we observed a decrease in the number of days on IV opioid therapy between Group 1 and Group 2. Looking at the results of the bowel regimen, we are making improvements with about 60% of our patients receiving prophylactic therapy in Group 2. We also observed a decrease in the number of naloxone administrations in Group 2, and with the continued monitoring of patients on opioids and recommendations of multimodal analgesia, we expect the number of naloxone administrations to continue to decrease. Some limitations of this study include the fact that the data analysis was completed on one area, the medical telemetry floor. There was inconsistency in the documentation of pharmacist interventions, and there were also a few confounding factors, which included the implementation of an automatic stop time for IV opioid therapy after 72 hours. So we can't really attribute the significant results of decreasing IV opioid therapy to pharmacist interventions. Another confounder was that some of the bowel regimens were already entered by physicians using admission order sets. I would like to thank the following people on this slide. And my self-assessment question is, what is one potential intervention pharmacists can make to ensure safe and effective opioid prescribing? And the answer is to recommend the use of stimulant laxatives with opioid therapy. Thank you.